Okay, sure. My name is Christine Sinnott, and today I'll be presenting my thesis research, modelling of the external radiation exposure to healthcare workers and the general public from nuclear medicine imaging patients. My supervisors are Mario and Pejman. So the main motivation for us undertaking this research surrounds radiation phobia from sonographers and other healthcare professionals. So it's quite a common scenario that a physicist will get a call asking whether it's okay to perform a procedure on a nuclear medicine imaging patient and any relevant precautions. So the physicist is then expected to provide an estimate of the cumulative dose from this interaction, as well as providing any radiation safety precautions, including bodily fluid contamination. So some examples of these scenarios are sonographers calling and refusing to perform ultrasound scans on patients who've had bone scans, dialysis calling and inquiring whether they can have a gallium-67 patient on the ward for about half a day, as well as some surgeries. So one of the examples, which I'll go into depth more later, is an F18 FTG patient being administered their dose, and then the nuclear medicine nurse realised soon afterwards that they had a liver procedure planned for 2 hours immediately after the scan. So the physicist was required to provide an estimate for the dose and then some safety precautions. So I'll just outline some of the annual dose limits here. So the ICIP publication 103 presents public annual limits as 1 millisievert, as well as consenting caregiving limits. So this is where people have been informed of the radiation risks and they've consented to getting extra dose. So this is people usually like parents of children undergoing radioisotope therapies, and they can consent to get 5 millisieverts. In addition to this, we then have radiation workers who are occupationally monitored, meaning they wear personal dosimeters, and they can have an annual dose limit of up to 20 millisieverts per year. So it's important to outline here that not all healthcare workers are radiation workers. So in some of the examples I presented earlier, sonographers, for example, are not occupationally monitored, meaning they're not radiation workers. This means that they will come under the limit of the public annual limit of 1 millisievert per year. So outlining some previous literature, which has looked at the external exposure from nuclear medicine patients. Young in 2013 undertook dose rate measurements from radioisotope phantoms filled with both water and F18, technetium-99m, gallium-67, iodine-131, and yttrium-90. He then undertook measurements up to 1 meter at 10 centimeter increments. From this, he was then able to determine conversion factors to normalized readings to 1 meter as well. So I presented a table here where you can see how the measurements have been undertaken. Mountford and O'Doherty in 1909 went further and defined the clinical groups interacting with nuclear medicine patients. So they outlined those interacting with the patient inside and outside of the hospital. So inside the hospital was people such as sonographers, nurses on the wards who aren't occupation monitored, as well as medical imaging technologists. While they define people outside of the hospital, such as spouses and people's parents and children as well. They also outlined the 2 main methods of measuring the external exposure from nuclear medicine patients. This includes the dose rate method, which is very similar to what Young has undertaken, where you measure the dose rate from a patient at a fixed distance. In addition to this, another method to undertake was the integral dose rate method. This is where you provide the people interacting with the patients who wouldn't usually be occupation monitored with a personal dosimeter. They wear this for a fixed period of time, and from that you can then determine the cumulative dose over that time. The limitations with this are primarily the fact that you don't know how much each interaction has how much dose each interaction has given. So modelling which has been done with surrounding nuclear medicine patients, mainly therapies, include Cormack and Shearer developed a mathematical model to predict the restriction periods for iodine-131 patients who are thyroid cancer patients. So they had 3 different templates with a bunch of varying tailored input. So this included contact patterns by hours, as well as including a lot more intensive input of exposure rate at specified distances, decay components for whole body clearance, and dose rates and dose rate limits, meaning that it was primarily used by medical physicists and didn't have the wider user demographic. Forster et al. In 2013 then expanded this and went and produced a user-friendly software called Delay or Not, or DAWN for short. This then used dose rates measured directly from the therapy patients to determine the discharge time as well as a restriction period, so providing estimates for these. But again, this was quite intensive, so it required the use of a medical physicist and it didn't encompass diagnostics. So I think This leads me to the limitations in the literature. So some further limitations, as I previously discussed very briefly, is limited radiopharmaceuticals. Due to the nature of the measurements undertaken, there is no set amount for radiopharmaceuticals, so you can't really see where the dose has been accumulated, and these studies were retrospective, meaning that the person has already received this dose, so there's no prediction of, of how much dose they would receive from a specific contact. In the times when there are measurements undertaken for dose rates from patients, there are at set times and distances, so usually immediately following administration and then at a fixed distance. This is not tailored for extended duration of contact, and it doesn't allow for multiple contacts either. This brings me to my project. So my project aimed to bridge the gap in this literature. So we had three separate aims. The first aim was to model the external exposure from nuclear medicine patients and provide radiation safety precautions based on the cumulative dose and the parties interacting with the patient. So we then wanted to translate this into a user-friendly software to be deployed for clinical use, so allowing for a much wider user demographic, as well as allowing tailored inputs, including the type of radiopharmaceutical, and the contacts will occur, as well as the duration of the contacts and the distance from the patient. And the third phase of my project and the third aim is then the validation of the model using physical measurements. So this is undertaking dose rate measurements from water phantoms, point sources and line sources to make sure that the cumulative dose is representative of a patient. So phase one was a mathematical modelling for my project. So this was based on two different publications or standards. So the ICRP publication 128 presents a wide array of the common radiopharmaceuticals used within nuclear medicine. In addition to this, they provide biokinetic models and data for each radiopharmaceutical, including the excretion, biological half-life, which accounts for excretion, uptake, retention, so as well as providing the equations and how they determine the cumulative dose. So this essentially accounts for the cumulative dose from that the patient has inside of them, and then we use the pamphlets to then convert this cumulative activity to dose. So the cumulative activity was multiplied through by an absorbed dose rate per unit activity to get the dose from interacting with the patient. So this is what we established in the model. So it's quite a large equation. So we have the cumulative dose as a focus, and then the first summation accounts for numerous contacts with patients. So this allows for repeat contacts at differing distances and for different durations. The next summation was then the summation over n effective half-lives. So as I mentioned earlier, the ICRP 128 publication does present biological half-lives. For each radiopharmaceutical, there's a few different biological half-lives with the fractional distribution presented, so how much, what percentage of that is the biological half-life in the body. So we sum over these biological half-lives we sum over the effective half-life which we obtained from the biological and physical half-lives. And then we first multiply through by the fraction of that effective half-life, and then we multiply it through by the cumulative activity. So we integrate the activity, administered activity, and account for the decay. So the integration occurs from the TI, which is the initial contact time, to TF, which is the final contact time. So these two times are then determined with respect to the administered activity. Once we've determined the cumulative dose, we then determine the gamma factor. So the gamma factor is the external exposure, which is in microsieverts per hour per megabecquerel. This gamma factor is essentially the dose rate per unit activity for a point source. However, because we're looking at the patient, we then have to account for attenuation that occurs inside the body. So this is what the self-absorption factor is for. The self-absorption factor essentially determines how much of the photons are actually emitted from the body and how much of the photons are deposit their energy and absorbed. The gamma factor presented here is taken at a reference distance. So this reference distance is usually at 0.3 or 1 meters. However, we allow for any contact distance for the patient. So this will then mean that we have to account for this, providing the reference distance divided by the actual distance and squaring this. This is the inverse square law. So the inverse square law basically states that if you double your distance from the source, in this case the patient, your dose will quarter. So we provide this as the default. However, I'll go into a bit more detail later, but we do also explore an exponent of 1.5. Some assumptions and limitations within this model outline the ICRP publication 128. It is based on a reference patient of a 70 kilo adult male. Obviously, not all patients that come through the nuclear medicine department are going to be a 70 kilo adult male, meaning that the anatomy between patients will vary. This will then vary the absorbed dose within organs and the absorbed dose deposited in the patient themselves, meaning the cumulative activity present will not be the same for everyone. In In addition to this, the organ function will also vary. So the biokinetics presented in here assume a normal organ function. However, some patients can have impaired organ function, especially when it comes to renal function, which could then also vary the biokinetics and the cumulative activity present within the patient. The mode model converting this cumulative activity to dose then works on the assumption of a uniform dose rate from the organs. So this assumption doesn't have any size or volume restrictions, so we essentially have to apply this to an entire patient. This would mean that we assume a uniform dose rate from the patient themselves, which is not the case. Due to the fact that radiopharmaceuticals are labelled, it means they will uptake in specific lesions and organs, meaning the activity within the body can be concentrated at certain areas, so this would not be truly representative. However, outlining all of these assumptions and limitations for our purposes here of providing radiation safety precautions and an estimate of cumulative dose, it's perfectly suitable. This is primarily due to the fact that we're not making any sort of medical decisions on treatments from this model, we're just providing safety precautions. The second phase of my project was then developing a user-friendly software. So the user-friendly software, I used Python, the tkinter package. So I'll present this GUI here. You can see that there's 6 different buttons to select from. And from this, it makes it quite user-friendly because it separates the inputs. So, and there's a lookup table button down the bottom left as well, which also provides immediate readout for this radiation safety precautions. So I'll go through a case study here so you can see the full functionality of the software. This is a study that actually happened in the nuclear medicine department. So the physicist on duty received a call from nuclear medicine nurses detailing that there had been an F18 FDG patient administered with 360 megabecquerels of F18 and FDG, and then for a 10 a.m. scan allowing for an hour uptake. However, after administration, the nuclear medicine nurse realised the patient was scheduled for a 2-hour-long liver procedure, and they called the physicist to estimate the external exposure as well as provide radiation safety precautions and any bodily fluid precautions. So you can see here in the first button, I've the administration details. You have the option to put in a patient name. There's also a drop-down list of the relevant radiopharmaceuticals. So the radiopharmaceuticals presented here were based on a list that the nuclear medicine department in Sir Charles Gardner Hospital provided us with over the scans for the past year. So we included all the relevant radiopharmaceuticals there. You can see I've also included the administered activity, date, and then the time. Once you submit the administration details, it will then provide a pop-up, and this pop-up will detail what you've put in, as well as outlining that the software is not suitable for therapies. The reason it's not suitable for therapies is because the ICRP 128 publication specifically states this when providing their models. The exposure from the patient button is the second one. So we input the date, the time, contact. So for this case, it would be 11 a.m. because that was when they were planning to undertake surgery. And the duration of the contact was 2 hours. The distance from the patient was estimated to be about 0.3 meters. This is as the distance is from the center of the patient to the center of the person interacting with the patient, in this case, a surgeon. It doesn't account for a straight dose. Once you have finished inputting this, you can either select Save Contact, and the Save Contact button will allow you to input repeat exposures. But in this case, we're just looking at the one exposure. So we select Finish Entering All Contact. Again, it'll provide you with a pop-up, and this pop-up will detail what you've actually input into the software. The third button down is then the advanced input options. So this is an optional button. You don't necessarily have to undertake it. There's default values saved in this, so the calculation can proceed as normal. However, this does allow for some more input for physicists. So in here, I've included the distance correction. So there is the inverse square law, which you can see here is in the drop-down menu. This is just a law that I outlined earlier in the model, where if you double your distance from the patient, it'll quarter your dose. However, we also explore the inverse 1.5 as well as an option. So we've included this here. The inverse 1.5 just changes the exponent from a 2 to a 1.5. The self-absorption and gamma factors are also presented here as an option. So we've included the AAPM TG108, which provides self-absorption factors and gamma factors for F18, FDG. The gamma factors and the unattenuated dose rate from a point source, and then we obviously have to account for the fact that there is some self-shielding with the patient, so we have to multiply through by a self-absorption factor. This provides a bit of flexibility in allowing you to select different literature sources, as well as us providing our own measurements. Finally, then you can select Calculate the Cumulative Dose. So this is where the calculation is undertaken, and then it will present what dose each exposure will result in. So the cumulative dose from these exposures was then 196 microsieverts. It also has the option to select the the safety advice to tailor it to relevant parties. But based on this, the medical physicist involved suggested delaying the contact to 3 p.m. And because the liver surgery wasn't an emergency, they were happy to accommodate this, and this made it 6 hours after administration. If we then input this into the software, you can see this has reduced the dose down to 41 microsieverts. So this software has then enabled us to reduce the external exposure from the nuclear medicine patient to the surgeon who would be performing the liver procedure, as well as all the nurses involved and other parties. In addition to this, the contamination risk from the bodily fluids have also been decreased. As the biological half-life explains, the radiopharmaceuticals excreted through the urine and the blood, meaning that if the person was to undertake this procedure earlier on, the urine would have been more of a risk, and similarly with the blood. Again, you can select the different parties interacting with the patient. So I'll go through these in a bit more detail now. The table presented here is the lookup table that was selected in the GUI. We have the 4 separate groups, which is radiation workers having a 20 millisievert limit, as outlined earlier, non-radiation workers, and then to the generic family and friends, which have 1 millisievert, as well as consenting caregivers, which have 5 millisieverts. The lookup table here is presented based on a traffic light system. So essentially green, meaning go ahead, yellow meaning delay the contact if possible, and red meaning to please call a duty physicist, as we may need to be present for any procedures. The limits that were selected here were based on being able to perform repeat procedures on varying nuclear medicine patients without reaching your annual dose. So we never want to give anyone their annual dose limit within one interaction with a nuclear medicine patient. So some further details on the safety precautions. We provide advice based on the time and distance from the patient, so usually providing COVID precautions of social distancing, as well as limiting your time unless absolutely necessary to be next to them. We also suggest delaying the procedures. So if possible and it's not an emergency situation, we suggest to delay the procedure to allow for time for the radiopharmaceutical to decay. In the case of an emergency situation, we request that we would be present to monitor for contamination and also deal with radioactive waste. We also suggest that request toxic precautions for bodily fluids. Such toxic precautions is an easy way for us to communicate with the ward that they need to wear additional PPE. This is because the urine is radioactive for the first 12 hours for most radiopharmaceuticals and for 5 days for gallium-67. The final button present in the software is the export data PDF. So this essentially, this export data PDF presents the patient name, the administration details, as well as group-specific precautions. In addition to this, it presents ward precautions and discharge procedures, so recommending that the medical physicist deal with any radioactive waste and check for contamination once the patient's left. The third phase is then the validation of the model with physical measurements. So we undertook measurements of dose, measuring the dose rate from water phantoms, line sources, and point sources. So the first measurement was the water phantom filled with a homogeneous mixture of water and F18, and then a homogeneous mixture of water and magnesium-99M. The measurements were undertaken at 3 different orientations, so posterior, anterior, and laterally, and they were measured from the center where the red X is out from 0.2 meters to 1 meter at 10 centimeter increments. The time at which the dose rates were recorded was also made note of, so that we could decay correct all these to present the dose rate per unit activity. Similarly, we undertook some point source measurements. So we used an embolism vial or a conical vial, which we put in a few drops of F18 and technetium-99M separately. We then elevated this in a polystyrene block to limit the attenuation from the surface it was sitting on and the surrounds as well. And then we undertook dose rate measurements from 10 to 30 centimeters at 5 centimeter increments. The final measurements that we undertook were the line source measurements. So these were taken, the line source was made up to 66 centimeters, and then the measurements were taken from the center of the line source upwards. So as you can see the schematic here. This was, the lead blocks were then affixed to either end of the line source to make sure it stayed flat. And we measured the surface measurement, and then we took measurements from 0.1 meter to 1 meters in 10 centimeter increments. Again, the decay corrected these measurements. So the overarching goals for this were then to have the distance correction, n. So we determined this using the, I've presented again, similarly to the inverse square law. However, we rearranged this to solve for n. And then we allocated one dose rate at the corrected and one dose rate at the reference, and we averaged this for each measurement and then averaged it over the entire orientation and again over the phantom to present the mean distance correction. The second thing we wanted to determine was the gamma factor. So we wanted to determine the unattenuated dose rate from the source for both the line source and the point source. I've also presented a gamma factor for the phantom. However, I am aware that this does include some self-absorption. And then third, we wanted to determine the self-absorption factor. So the self-absorption factor is the attenuated dose rate, in this case the phantom, divided by the unattenuated dose rate, so the line source and the point source. This will then present how many of the photons were absorbed and how many of the photons actually made it through the patient tissues. So my results are here presented. So the results presented are the mean plus or minus the standard deviation, with the percentage in brackets being the standard deviation as well. So you can see here the phantom and the point source both agree with the inverse square law, while the line source agrees with the inverse 1.5, where n is equal to 1.5. So due to this, we included both the inverse square law and inverse 1.5 in the software as advanced options. We then have a look at the self-absorption factor, and you can see here the F18 self-absorption factor for line and point sources are quite consistent, whereas for technetium-99m, the point source is significantly higher. This suggests that only 8% of the photons were actually absorbed within the body, which, considering the fact that technetium-99m has a much lower gamma activity than F18, so technetium-99m has 140 keVs, whereas F18 is a PET isotope and has 511 keV gamma photons. Due to this, we would expect F18 to be significantly have a significantly higher dose rate and higher and have more photons emitted through, but this is contradictory to what our results show. And the gamma factors presented here are all normalized to 1 meter. So we use the distance corrections we previously determined. So the phantom and the point source were inverse square law, while the line source was inverse 1.5. So comparing these to the literature, you can see the self-absorption factors for F18 agree quite well with Yee's paper in 2013. And then technetium-99m, although it does agree with Yee's literature, we disregard this primarily due to the fact that it is extremely close to F18 and the point source was also significantly larger. To rectify these measurements with the point source specifically, we would suggest an increased specific activity be used for the point source itself. The gamma factors are also presented here, and you can see that the point source for F18 agrees very well with the literature. So we included this in the software. So we included the gamma factor and the self-absorption factor in the software for F18 as an advanced physicist option, whereas technetium-99m, the results for the point source don't align well with Unger and Truby's gamma factors. So again, we would suggest undertaking these sources again because we can attribute this to low specific activity, meaning the further we got away from the point source, the more the dose rate measurements became like background. I've included the line source here so that you can see that the line source for the gamma factor does align with Unger and Truby, which suggests that it is specific activity. So some conclusions for my project is the mathematical model was successfully constructed and provided a cumulative dose based on the external exposure from nuclear medicine patients, as well as differing interactions which you can customize. This was then successfully translated into a user-friendly software which aligned with the model. There was no discrepancies between the results presented in the user-friendly software and the mathematical model. The F18 measurements also aligned with the literature, presenting self-absorption factors and gamma factors which we could use in as advanced options. The software overall provides tailored radiation safety precautions based on the relevant parties selected and provides this in an easily accessible way for anyone of varying radiation backgrounds to understand. Some future work that I would suggest is undertaking patient measurements within the nuclear medicine department. This would allow us to gather information for a variety of radiopharmaceuticals, as well as for a variety of different size patients, all accounting for the size of the patient to produce the self-absorption factor. In addition to this, I would suggest undertaking additional radioisotope measurements, not just for technetium-99m and F18, but also including indium-111, gallium-67, and other common radioisotopes. Again, I would suggest repeating the technetium-99m measurements to get more statistically viable results by using a higher specific activity. I'd like to say a massive thank you to my supervisors, Mario and Pejman, for your support throughout this and all of your advice. A big thank to medical technology and physics for their continuing support and feedback. Thank you to the nuclear medicine department, in particular, Paul and Elaine, for facilitating my measurements. And a big thank you to the medical physics research group and the master's students as well.
Fantastic. Thanks, Christine. That was an excellent presentation. I actually have a couple of questions, if that's okay.
Yeah, sure.
So one of the things I was wondering is just about the actual software itself. Like, it seems extremely useful, not just for Charlie's, but potentially for other hospitals as well. What are your plans with the software itself?
Sorry, I've just made it into an executable, and we've been playing with that a bit and making sure it actually works when I don't have the code in the background. So I'm hoping to undertake the future work measurements and get some patient measurements to make it more representative of an actual patient. And then hopefully I'll publish it and maybe make it open source so people can have access to it. That's like the long-term plans.
Yeah, excellent. That sounds like a great idea. Just one more question. Was there any particular administration that you noticed had a large dose or larger relative to the other administrations during your testing?
By dose, do you mean the injected activity for patients?
Yeah, so like well, exposure, I suppose. Yeah, so like, is there any particular administration that you noticed with your software as you were testing it that gave a particular high exposure to radiation workers or staff?
Okay, so FAT and FDG definitely gave the highest exposure, but I would potentially attribute that to the fact that it does have higher gamma energies of 511 keV. So because it's not so much shielding, it had a larger exposure. That's primarily what I use for testing to try and get that result as well.
Yeah, okay. Excellent. Pejman or Rashid, did you have a question?
Yes, thank you. Thanks, Christine. That was fantastic. I have a question about your software in general. So who is going to use it? Is it going to be the sonographers who are worried? Are they going to run it, or are you going to, for every patient that goes there, do they ask physics to run the program?
So currently what happens is usually they'll call the duty physicist in medical technology and physics and request the external exposure and request this radiation safety precautions. So I've designed this software to be able to be used by people who don't have background. So all they really need is to know what the patient received and when. And then the radiation safety precautions provided will detail whether it's safe to go ahead without any precautions, but also giving details of if it's not safe, what to do and who to contact as well. So I've designed it so that it can be used by both physicists and any other person, but it does give you contact in case they have more questions as well.
Excellent. And one more thing, with the technetium.
Yes.
So regardless of the issue that you had, like with the distance and what it was different to what you expected, in general, if it shows that the exposure would be high, are there any precautions to use so that the patient can be scanned?
So generally, if the exposure was high, we'd recommend that we'd provide people with personal dosimeters so that we could actually track their dose. But in addition to this, we would recommend that they don't spend any unnecessary time next to the patient, as well as any bodily precaution fluids. So say they were had incontinence, we'd have to make sure that we collect all their incontinence pads if they've been administered that morning. But mainly, if possible, we would recommend delaying the scan to allow for time for both biological excretion and physical decay.
Mm-hmm. So there is no lead glass or something that like a moving lead glass so that they can.
Yes, no. Yeah, if it didn't interfere with any of the imaging, then yes, we could definitely recommend that they use like glass. But for people like sonographers, where they're scanning people's abdomens, it'd be a bit difficult to implement this. But I think it would definitely be beneficial using like glass, especially for technetium.
Sure. Okay, thank you.
And Roger, you'd like to ask a question?
Yes, thank you. Christine, that was a fantastic talk. Thank you very much. It's very relevant, what you're doing. I've just got a quick question about practices, say, in a radiopharmacy lab, where very rarely, but occasionally you might get a spill on the floor or something like that. Not really dealing with the situation where the worker has it splashed on themselves. I imagine that would be more complicated. But I presume that you could, your software could be made relevant for a more disseminated splash of a radioactive liquid, say FDG or something like that, just by changing the distance factor rather than a line, rather than 1.5 to make it somewhat less. It'd have to be empirical, of course. Any comment on that?
So I think as well, I've had this suggestion by the radiochemists themselves, but I do think as well we'd have to account for the specific, like the concentration of the spill as well as the area of the spill. So essentially, when I was looking at implementing this, I would think that it would be a different software or a slightly different window. primarily because you would have to account for the area of the spill as well as the concentration, like whether it would have high specific activity. So I think as well, the distance correction would also need to be accounted for, because the line source seems to be representative by 1.5, but the point source measurements weren't super great. So I think, and a lot of literature sources that I saw said the point source was too conservative, especially for spills and that.
Thank you.
Fantastic. Thanks, Christine. I think we'll leave it there then. Again, thank you for that excellent presentation.
Well, thank you.
We'll stop the recording.